We up later. It's been a long meeting. I say 11:15.
I'd like to call the meeting to order. Chelsea, you mind to do the roll call?
Mrs. Blackwell.
Here.
Mr. Caldwell.
Here.
Mr. Bishop.
Here.
Mr. Fogel.
Here.
Mr. Kirkland.
Here.
Before we begin, we've had several bad things happen this week. Casey Schaefer, child of an employee, has passed away. Charlie Sipes, a child of an employee, and Jim Thomas's father, James Richard Thomas, passed away, as well as some other members of the community. If you don't mind, let's take a moment of silence. Thank you all. Appreciate it. The first item on the agenda is consider approval of minutes of previous meeting held Thursday, September the 5th, 2019.
Motion. Second.
Mrs. Blackwell.
Yes.
Mr. Caldwell.
Yes.
Mr. Bishop.
Yes.
Mr. Fogel.
Yes.
Mr. Kirkland.
Yes.
The next item on the agenda, we have some special guests with us tonight. Terry Bergen, Health Promotion Manager, Jennifer Osborne, the Harm Reduction Specialist, and Sarah Jo Best, with Lincoln Trail. Also, Dr. Mark Ackerman is going to try to make it before the 4 o'clock, but he's working today. So what he has done is left a letter to read. We're going to discuss the needle exchange program here today, and Terry was at a Lincoln Trail Board of Health meeting a couple weeks ago, 2 or 3 weeks ago, and give some situations that this program has helped some individuals, and I thought it'd be great for her to come today and discuss it with us, as well as Jennifer as well. So welcome to the court meeting.
Thank you.
All right.
It's okay, or?
That's fine. Yeah, whatever you feel comfortable with.
Thank you for having me here today. I am going to talk about the harm reduction syringe service program, and I'm going to drop that down to SSP. So whenever you hear SSP, that's what I'm talking about. And every one of you has slides in front of you. If you want to go ahead and open that up, you can follow along. I'm on slide number 2. First of all, I just want to say that the SSP is, a lot of people think of it as a solution to the drug crisis that we're experiencing right now in the nation. It is only one solution in a community effort, one harm reduction strategy and a community effort towards stamping out this opioid and illicit drug use that we have going on. It's a good solution. It's an evidence-based one. That's one, but it requires everyone to work together. I wanted to give you a little bit of background on SSP. They've been in existence since the early 1980s. So they've been around quite a while. And they were initiated to kind of help stamp out communicable disease in neighborhoods, in communities. It started in 1988 in Tacoma, Washington, for the United States because of the HIV/AIDS epidemic that had hit in the United States at that time. They are evidence-based. The heaviness of the, I cannot stress enough how researched and evidence-based SSPs are, and I'm going to be relying on that as part of my presentation going forward. So if you guys want to move on to your next slide. Be on slide 4. Although the research is extensive, there's still a lot of myths out there, and I'm going to correct the top 3 that we hear most often whenever we present. The top 3 myths that we hear most often. So a lot of people think that the only thing that SSPs do, we're on slide number 5, is to give out needles, so that's not the case at all. It's so much more than a needle exchange. Every time a client walks through an SSP stores, we are afforded the opportunity to help them. We're a resource for people who inject drugs to treatment programs. That's one of the big things that we do. We test for HIV and hepatitis C. The HIV test takes 60 seconds. The hepatitis C test takes 20 minutes. so we can get them in and out. One visit can take about 30 minutes or longer or shorter, depending on what the client wants to have done there. They also have access to Narcan kits, depending on the exchange. The one that we operate in Nelson County, we have an agreement with Medical Pharmacy. Our clients can go there, pick up a Narcan kit. And so part of that, getting that Narcan kit, they are provided overdose education as well. So they're educated on overdose prevention. They have access to the health department services, so they can be tested for STDs. And they have access to vaccinations. When the hepatitis A outbreak occurred, our clients who came through the SSP were vaccinated against hepatitis A. This is a pretty big deal because a lot of times our clients who visit the SSP do not seek out regular traditional care. One way they do that is by coming through the syringe, the SSP. We open that door a lot of times for people that don't want to seek care at all. You want to move on to the next slide. Slide number 6. Another myth is that SSPs only enable drug use. Many of the general public still believe that that's what happens, that SSPs kind of help enable drug use, but in fact, it's just the opposite. New users of SSPs are 5 times more likely to enter drug treatment. And if they come on a fairly regular basis, they're 3 times more likely to stop using drugs. And I have a story, I want to kind of drive this point home. We operate the Nelson County Syringe Service Program. We do not know their names. We fill out participant ID codes. They come in anonymously because we want them to feel confident and safe in coming. So the name that I'm going to use right now is not the person's real name. Cindy is what I'll call her. She was a client of our Nelson County SSP. Her drug of choice was heroin and meth. She came to the SSP because she could obtain clean supplies, and she was worried about her health. Cindy stated it was the one place that she could go where people actually helped her. The relationship that was built over the months and year that Cindy visited the SSP led her to seek treatment. That relationship is so important. Cindy has been sober now for over a year. She went to detox. She has regained custody of her 2 children. She has a full-time job. She continues to see a counselor, and she remains HIV and hepatitis C negative. Last slide, third myth, SSPs undermine public safety. We also hear that a lot of folks are concerned that SSPs are just a magnet for people that use drugs. Everybody in everybody else's county is going to come to my SSP. And the research and the data just doesn't prove that. Most of the folks who use SSPs live in that neighborhood. They don't travel a lot of time outside of their counties. Not saying that it doesn't happen, but they don't travel a lot of times out of their counties to go to another SSP. SSPs have been proven to reduce the needle stick injuries experienced by police by 1/3. And it doesn't make a difference in the crime rates, meaning it doesn't increase crime rates in your community. There was a study done in Baltimore where break-ins and burglaries fell by 11% in areas that had an SSP and increased by 8% in areas that did not. The next slide, the evidence is strong that SSPs work, and you can see on that slide with the Kentucky map that reflected in the numbers across the number of SSPs that are going across Kentucky. Right now we have 63 SSPs in operation in 59 Kentucky counties, and that number is growing because it does work. It's a solution. It's a harm reduction solution. Now, I would like to kind of provide you an example of a SSP that's local, and I'm talking about the Nelson County one and how well it is working. On slide 9, you can see our hours there. If we are open, we operate out of the Nelson County Health Center, so if one was to be here in Marion County, it would be out of the Marion County Health Center. Currently in Nelson County, we operate 3 days a week. We use 3 staff members to do that who have gone through harm navigation navigation training. It's a 4-day training that's offered by the Kentucky Department of Public Health. And we also had to attend the fundamentals of HIV counseling. We have to do that as well in order to work in the syringe exchange. So we're training personnel. Now, on slide 10, you will see a picture of the one room that we work out. We don't need a lot of space to do what we need to do. It's a single room. It houses all of our supplies, our equipment, the paperwork we need to take care of our clients that come into the SSP. On slide 11, over the past year, so we're talking, the data that I'm going to represent for this particular SSP for Nelson is from August of 2018 to August of 2019. We made a few tweaks and changes in the program because we wanted to make it a little bit better. On average, I'm on slide 12 now. Now this one's a little bit different. This is from inception. So since the inception of the program, which is July 2017 to July of 2019, we've seen 203 clients, unique visits come to the SSP, a total of 903 visits. So they come back to see us. And on average, we see about 9 new clients a month. On slide 13, our syringe ratio dropped drastically after we tweaked the program and looked at our policies a little bit. So for August 2018, it was 2.76 for every one. It's dropped down to 1.64 to every one. And as I explained to our board of directors, it's not a true one-to-one in the sense that they come through that for that first visit and they have no syringes. So we can't expect them to return something that they don't have. The second 2 visits are kind of free because it gets them used to the idea of bringing those syringes back. We give them black sharp containers, so they dispose of them safely in the sharp containers that we give them, and they bring those back to us and we dispose of them so they're not on the streets and on grounds. Slide 14. Since those changes, so now I'm talking August 2018 to August 2019, we have seen an increase in our HIV and hepatitis C testing by over 30%. We have reduced program costs by 55%, and we've increased referrals into the health department and drug treatment services programs by 60%. And that completes my presentation. Do you have questions for me? Well, no, sir, I didn't bring, I just print those out, but I can have Jennifer get some pictures.
I'm quite sure the department of the youth working, and a lot of people lose their kids because of the government, and I'd like to see them get the kids back.
We will definitely have Jennifer drop some off.
When is this, say, if this passed or moved forward, how long does it take to get this set up and going, or?
Well, it'll be a little bit easier this time because we're not starting from scratch. We still have to get our staff trained to go through the program, and then we have to order supplies and get everything up. So I would say about 2 to 3 months.
And city council would have to approve it.
That's the other thing.
But you have room at the, this room will probably be at the health department, you have space and all up there?
We would use existing staff and existing space.
I talked to Judge Watts in Nelson County, and, you know, you hear a lot of negatives about it, but there's a lot of positives as well. He's glad that he's done it. If it's helped one person, honestly, it's worth doing. And, you know, to see those people get into some type of treatment is really, really positive. Yeah, Dr. Ackerman couldn't be here, so.
Says that no one can deny the increase in drug use across the entire United States. Marion County is no exception. In my practice alone, we have seen a huge increase in drug use. It has gotten so bad that we do universal drug screens on every pregnant person that comes to our office for care. This is not to be punitive, but to try and get those that need help to the proper sources to help them. As a result of the increased drug usage in pregnant women, all the nurses that take care of infants at Springview Hospital now have to be trained in neonatal abstinence syndrome, which is newborn drug withdrawal. This is a common but sad reality of our practice. With this new drug culture, we have seen an increase in hepatitis C, and an increase in HIV is likely soon to follow. This problem is not going to go away anytime soon and is likely to get worse. What makes this more dangerous to my patients is that a lot of them will exchange sex for drugs, or they will be taken advantage of in an intoxicated state. Sexually transmitted diseases are much higher in this patient population, and with that there is increased risk of transmission of hepatitis C and HIV. How does all this pertain to the needle exchange program? This program is not going to solve the problem, but it is one of many steps required to start making a change. People who come into the needle exchange program are realizing that the life they lead is putting them at risk, and that is a first step in getting help. Needle exchange has a chance to decrease the spread of hepatitis C and HIV among these users, and in turn will help to decrease transmission to the people that they have sex with, especially if they agree to be tested for hep C and HIV. This decrease in transmission could potentially decrease the number of babies born with hepatitis C and HIV. In an ideal world, we would not be dealing with the drug crisis at all. Unfortunately, we all know that this is not being realistic. With these things being considered and adding a chance to get people into treatment, I give my full support to the needle exchange program in the hopes of protecting the most innocent of all, our unborn children. And that's from Dr. Mark Ackerman, who does sit on our county's board of doctors.
Okay, the needle that they get in the exchange, it's good for one-time use?
One-time use, but having said that, a lot of them use it multiple times.
We do a lot of education with them now when they come in about the risk of using someone else's needle, but also the risk of using their own needle multiple times too. So we do provide that education and encourage them to only be using one time.
Okay, so therefore, if they come back in to get the second needle, they should bring the first needle back, but they don't have to.
Well, now, the first 3 visits is kind of education and creating that culture of they need to bring the needle back.
Fourth,
The 4th visit, they are held accountable for bringing the needles back that we give them.
And
Okay.
we track all of that in a database, so we know how many they were given at their last visit. We put in how many they returned. So we can see each visit, what they were given the prior visit. And if we're not getting that many back, now I don't sit there and, I'm not going to touch everybody's needles and count them.
right.
But we ask how many are in your box, and most of them, I can tell if there's 10 needles there or if there's 70 needles.
Okay, so how many needles do they get?
The max that they can get is 70, but we have some folks that inject up to 10 times a day. Regardless of the amount of times that they inject, 70 is the max that they can get at one visit.
And they come monthly or weekly?
We are open, we're open 3 days a week, so they can potentially come 3 days a week.
But I had a young man the other day that told me he was injecting 15 times. 70 needles isn't going to last him a whole week.
Wow.
If they come in and for the needle exchange, do they have to be tested? They can opt out to being tested.
We cannot make them be tested for HIV or hep C. We just strongly encourage it. And so the way we talk to them, we build that expectation that we expect them to be tested. And one of the things that we have recently done, because the state has kind of moved us towards this way, is that we were looking at having them tested every 6 months, because sometimes it takes the HIV and hepatitis C antibodies that long to build up and be recognized in the body. But the state wants us to test them every 3. And so that's what we're moving to, every 3 months. Or have already moved to.
So most of them agree to be tested?
Most of them do. Most of them don't have a problem with it.
Some of them have already been tested in other places, and other statuses.
Probably
That's reported.
On the same but a little different, what is it? There's 3 different types of hepatitis.
Hepatitis A, B, C, and there's another one, like a D. There's more than 3.
I know, like years ago, a bunch of kids, well, I had it, and a bunch was in school. This was 40 years ago, 50 or 100 or how long it was. But it was that makes you turn yellow, and it was, I think, a food, you know,
Yes,
is that what that is, Hep A?
hepatitis A.
Okay. But I mean, you know, you get over it, but some of them had to go to the hospital, but it was something to do with contaminated food or something.
That's Hep A for sure.
Okay. I knew there's 2 or 3 different kinds. And the old one, they keep advertising on TV, you need to be tested for Hep C if you're so old or something. What is it you got to do? Is it something in your blood or something, or?
No, hepatitis C is one of those, one of the viruses, the hepatitis C viruses that you can get through injecting drugs and through sexual intercourse. A lot of times, especially in the older generation, 60s was a time of just freeness. You know what I'm saying? And so there were some things happening that probably shouldn't have. And so a lot of times people were exposed to things that they may not have been exposed to. And they're finding out later that hepatitis C might have been one of those things.
You get the
They're left untreated.
when you get the hepatitis shot, say at the pharmacy or whatever, does it cover all of them, or what?
No, sir.
Which one does it cover?
We only have one for A, B, and A and B.
Oh.
Hepatitis C is curable, but you have to go to see a provider and get treatment for that.
Okay.
We don't have a vaccine for hep C.
So the ones like when you go to the pharmacy every year to get your hepatitis shot or whatever, it's for the A and the B?
And then the Hep A, once you get 2, you're done.
Yeah, I know, yeah.
Hep C, 3, you're done.
Okay.
I mean, B, excuse me, B, yeah, Hep B, you're done.
Hepatitis C left untreated typically will cause your liver to fail and death and that liver transplant.
Yeah.
Yeah, I took some type of hepatitis shot a few years back because we handle a lot of wastewater. Now, are they good forever?
They are, once they have that third one,
Okay.
you're good.
Well, I mean, I went over to Dr. Scott. I mean,
But we've seen in the corrections where we see a lot of the hepatitis stuff come through and the Hep C, and that's what I brought up about a few weeks ago. What I seen at a national conference just a month ago was the Hep C. There's 2 states, Tennessee and Florida now, are mandating on the offenders that are incarcerated people to be tested for Hep C. What we run on the medication for us, like at the jail, it's about $39,000 for a treatment. It can be cured, but it's expensive.
It can't be prevented. Which is
That is even,
program.
Is
costly.
is it true you can have hepatitis C and not know it?
Yes. That's why they're encouraging.
That's one they advertise on TV to go get tested if you're so old people like
so
me.
me and you gotta go.
Yeah, I do for sure. I don't know.
You know,
I was around the 60s. That free stuff.
It's a subject that nobody really wants to talk about. You don't want, a lot of people, if your family hasn't been affected by it, you're very lucky. It's hit just about every family out here. There's some that it hasn't. But things people don't think about with these needles either is just the day-to-day, your EMS, your police, your firemen, everybody's exposed to it, and it's more and more out here in the public. I had an employee get stuck by a needle trimming shrubs, and we're going through a year-long process getting him tested because they threw needles in the shrubs, at a restaurant, and it could have been a kid, it could have been anybody. So,
well, but my mailbox, I live way down there.
Well, another point I want to make
I guess they
is,
heaved it out the window.
if you remember last year, you seen on the news about the community in southern Indiana, it just about bankrupted them. And
Because of an HIV outbreak.
exactly.
That should have been
So, I had one phone call this week, I've just had the one, and they were very against it. But their family had not seen any drug addiction, they had not really experienced anything, and nobody's proud of it, nobody wants to talk about it, but it's reality. So.
I will say that our clients that come through the Strange Exchange walk a whole, they come from all walks of life. Our main group are white males, but almost 40% of our clients are employed. A large percentage have health insurance. So it's very eye-opening. I can say that my world has been changed just by working with the contract.
And the cost too is all, you all take care of all that, it's all,
The majority of how we pay for the program is through application for grants. So most of it's grant funding that we receive from the Department for Public Health. Sometimes some of our coalitions will help us, some of our anti-drug coalitions will help us with some funding to buy some supplies and things. And then we use current salary, current grounds, current buildings, so we can keep the cost to a minimum.
Well, on your little chart you gave us, Marion County was in the white, which is good, right?
No.
I know, that's what I was gonna say, because our surrounding counties, Greene, Taylor, Casey, everybody else was in the green. And I thought right then, boy, Marion and Washington are very lucky and they need to stay off the green.
But the thing is, if we are, if our neighboring counties.
That
are
close.
around, that is close. I mean, that could easily slide over in Marion County, right on ahead of the game.
my point is, doing nothing is not gonna help either. If we don't do anything, there's not even an attempt to help, so I don't think we're gonna vote on it tonight, or anything, but, like you say, the next step we would do would be pass an ordinance. Is that what we'd have to do? Talk to the city.
Is that what had to draw up, and kind of like the city and the county draw up like a ordinance between, use the same ordinance, or it has to be different? I mean, can it be can it be like the same ordinance for both
Okay.
bodies? Or do we have to have a different one than theirs, or can it pretty much say?
They would have to do their protocol, and then we would have to do one as well.
Okay.
We could make it do.
They can be similar, but just
Right.
different.
The city would have to do the same?
Yes, we have to get it passed by the Board of Health, which is already happened.
Yeah.
And then it has to be passed by the school board, and it also has to be passed by the city council in which it operates. Since our building is
We will be on their agenda.
yes.
So will you all come back to us after you speak with them, or?
If you all want to send me a draft of what you have, we might look at it.
I mean, I feel sure it get it passed.
I think everybody's in favor of it. Just going through the, getting the legal, check it out.
Thank you all.
Thank you.
Thanks for coming.
You ladies.
Is anything else going on at Lincoln Trail?
Great day. All good stuff.
Permits. That's what interests me.
All right. Well, thank you all very much for coming. Appreciate it. Jennifer, thank you.
Thank you all.
Jason Terry. Came over and leave by sleep. Yeah. What do you do, bring a strong arm in here? What do you do, bring a strong arm in?
He's been out fighting all day. You gotta have a bodyguard with him.
He picked a good one.
Thank you, girls.
Thank you all.
Thank y'all.
Appreciate it.